Hi, everyone, and welcome to a new episode. I'm pleased to welcome my special guest, Dr. Konadu Fokuo. Do you mind giving just a little overview of your current position right now, Doctor?
Yeah, so thank you for having me. My name is Dr. Konadu Fokuo. My current position is that I am an assistant professor at the University of Illinois at Chicago.
Okay, wonderful, wonderful. And so what I understand is you completed your PhD in clinical psychology with a specialty in rehab psych at the Illinois Institute of Technology, and your internship and postdoctoral fellowships were at the University of California, San Francisco.
Yes.
Is that right?
Yes. That's correct.
And I know you just have a range of different specialties, but would it be accurate to say that your efforts are focused on developing targeted interventions for people with behavioral health disorders?
Yes, a little bit broader than that, but yes, that is essentially what I do.
Okay, great. We'll definitely get in more into that. And I know you were also very blessed to receive an early career award, which we'll definitely talk about in more detail. And you used that award to help with a project to study stigma in healthcare settings.
Yes.
Great. So you're very accomplished, and I really want to get into the journey that brought you to where you are today. So let's start with something that we share in common, even though we just met, which is we have a tie to Ghana. Now, I believe you were born there, whereas my family is from there, but I was born in the US. Oftentimes, I would be threatened to be sent there if I misbehaved, but that's a whole other story we'll get into later. But I'm just curious to start. What was it like growing up in Ghana?
Ghana's great. I have no qualms. I enjoyed it. I grew up in Ghana. I was born in Ghana. I was born in Tamale. My dad is a minister. He's a reverend. He's a Presbyterian reverend, actually. And he and my mom were helping to establish the Northern Presbyterian Church. And so that's where I came into this world. I lived in Ghana most of my until I was about 6. My dad got his doctorate at the Louisville Theological Seminary. And so my family moved to Louisville. And we lived there from 92 to 96. So you can think about all the things that happened in American history from 92 to 96. And then we moved back to Ghana. So then I did middle school and high school in Ghana. And my parents could not threaten to take me back because I was already back. And then after that, when I was around 16, I was done with high school, secondary school. And my parents and my brother was still in Chicago, actually. And so we had a little discussion, and I was very interested in psychology and wanting to do something in psychology, but not really knowing the words for it. And so they were like, listen, if you want to go stay with your brother, let's see how a year goes. If you like it, you can stay. If you don't, just come back. And so I moved to Chicago, and I lived with my brother, and he was my guardian, and it was an interesting year, and I liked it. So I stayed, and my parents were willing to let me stay as well, so that helped. But I go back home every year. I try to go during Christmas because it's fun. But you can also go during the summers, and it's also fun. But I enjoy it. There's nothing better than like landing, and then you have to go down the stairs of the plane to get onto the bus, and I'm just like, yeah, I'm home. Like I'm officially home.
The Quaba.
Yeah, if you go during Christmas, they have all the drummers out, so the drummers are playing as you're coming out of the airport, and yeah, it's a very good feeling. If someone ran up to me and gave me some kenke or some wache, it would be like official, the best. The best return home ever.
Yes, jollof, fufu, all that, all good things.
Yes.
So I noticed something you said, which is that you go home, and by home you meant Ghana. And I know for a lot of people, even sort of like myself, who have had this sort of transcontinental journey in their life, home can be very subjective. You're currently practicing in the US in Chicago, but you consider home Ghana. And so I'm curious for you, that journey you've had of growing up in Ghana, then coming to the US for a bit of time, then going back and still kind of considering Ghana home. How has that been for you? Do you see it as a positive, or have there been a lot of hard aspects of having two different kind of homes that you kind of go back and forth between?
That is an excellent question. I think for a lot of 1.5ers, people who lived somewhere and then came back and then lived somewhere else, I think it can cause some difficulties with adjustment and some transitions. I've been very fortunate. So yes, I say Ghana's home because my family is in Ghana, but I will say, because my Ghanaian family says this too, when I'm coming back to Chicago, I'm like, oh, I'm going back home. So it does go both ways. I don't see it as a disadvantage. I suppose there could be some disadvantages. And I suppose when I was younger, people would say things like, oh, like you haven't been in Ghana a long time, so you just don't know, right? Like, oh, no, like it's not like that here. It was like that when you lived here, but not anymore. And I remember my younger self would be like, how dare you? I'm from here. But now they're right. Like I've lived in the US longer than I lived in Ghana. And there are some things that are occurring in Ghana that I may know about, but I'm not experiencing. And so some people are correct in that way. But I do think because I consider Ghana home and I consider a lot of the things that happen in Ghana, including mental health initiatives, to be something very close to my heart, I work at it, right? So I network with professors at University of Ghana. I'm hoping to put in a grant to work with the University of Ghana. So I think that it can be a hindrance if you get a little bit, as they say, in your feelings. But if you're willing to explore a little and be flexible and figure out how you can help, where you can help, especially as a clinical psychologist, and with Ghana going through a lot of work so that we can now be licensed there and work there and help there and think of culturally adaptive interventions there. I think why not? If you're a researcher, there's grant money in international work. And I have an in. I speak the language. I'm from there. My name says I'm from there. I know a lot of the culturally different ways to adapt Americans' interventions for West Africa, specifically Ghana. So, I think it broadens my research, my program of research, and it also gives me an opportunity to give back to a country that I love. So
I'm really glad you have that very positive outlook and benefit from that, because even for me, I have this duality where when I'm in Ghana, I get very much reminded that I'm American, but when I'm here in the US, I get little reminders that I'm Ghanaian. And I'm wondering, do you have that sort of thing, or is that just me? Sort of the idea of like, oh, in some ways, there's sort of yin and yang going on with me.
No, I don't think it's just you. I think I think it's normative, right? It would be weird if you were in Ghana and no one recognized that you have an American accent, or that you have experiences that are not 100% that of someone who's lived in Ghana their whole life. Same in the US, right? I mean, in the US, we are also just taught to be able to like single people out, right? Are you in group or out group? In group or out group? So it is kind of normative. I honestly think for me, the reason it's not, so I guess two things. One, when I went to college, right? So when I went to undergrad in a great institution, Carleton College in Minnesota. But when I got there, it was because I had just been at an all Black high school. Well, I had been in Ghana, which was all Black. And then I went to Chicago to a predominantly Black high school to finish up there, and took some classes at U of C as well. But I was still kind of like around a lot of Black people, right? And in Ghana, everyone called me Konadu. And when I got to the US, I was like, oh, I should use my first name so that it's easier for people. And I remember like in high school, just like everyone called me Joyce. And then one day a friend came home and I was talking to my brother and he was like, Nana, Konadu, what are you doing? Da, da, da. And my friend was like, wait, what does he call you? And I was like, oh, a lot of people call me Konadu. And she was like, well, why didn't you just tell us your name was Konadu? And I was like, oh, I don't know. I wanted it to be easier for you. And I vividly remember this. And she told my friend, her name is Dominique. She was like, do you not hear the names we have at this high school? Do you not hear and see how complex people's names are? Like, Konadu is not a hard name at all. Like, it looks the way it sounds. And I was like, oh, that's a good point. So when I went to college, and now I was in a predominantly white institution, I was like, man, Dominique, should I tell people my name is Konadu, or should I just go by Joyce? And she was like, it's not a hard name. Everyone will understand. And everyone did. It did become a subject of conversation, right? Because I sound very American, but then my name is Konadu, and people are just like, oh, where are you from? And so for me, it became like a way to introduce myself, a way to have conversations, a way to connect with people. And I've also been very fortunate that it might also be some selective bias on my part. I tend to find myself in groups of people who have a lot of cultural exposure. So, I meet someone who is white American and I'm like, hey, where are you from? And they're like, I grew up in Peru. So, I've been very fortunate to be able to meet other people. And maybe because also like I might be seeking that subconsciously, but I've been very fortunate to be in the company of other people who've had to traverse these two cultures. And fortunately for me, it's been relatively easy without feeling as though sometimes we get some judgy people, but for the most part, it feels like people are welcoming and open and willing to hear what I have to say, which is nice.
Good. I'm glad you have that.
Nice. I don't talk about Ghanaian politics though, because people will cut you down very quickly. Very quickly. So that I'll just sit there and nod.
We can talk about that offline.
Yeah.
What's interesting is even in the span of this conversation, you've thrown out a lot of terms that tell me you're a psychologist. You talked about in-group, out-group, selective bias, subconscious. So I can tell, like, oh, you've definitely done this
all day. Yes.
Which I love. But let's go back because you mentioned that interest in psychology. And I'm actually interested, growing up with a father like you had, was there ever sort of a dissection to you of how to heal through faith and through psychology services, and what kind of sparked that interest from, this is something that I can do for a career, or at least let's just not even say career, but for a study?
Great question. So, like I said, my dad is a reverend. He was a reverend before I was born, so I've only known him as a reverend, although now he is retired, so I know him as a retiree who still preaches. That's where I came from. But within my family, I have 3 other siblings, right? I'm the youngest of 4. And my second sibling, who's my oldest sister, she has autism. And I'm talking about, this is 1978 autism, right? So no one knows what it is. No one understands what's going on. And so I grew up in a family where mental health was very obvious, right? Like, she would have vocalizations. She would have difficulty expressing herself. She would get irritable. And my family just took it as like, this is how I grew up, right? I grew up as that kid who just assumed other people's siblings had vocalizations. Like, I didn't realize my sister was in special ed until way too old. I should have figured it out much earlier. But I just thought this is life and this is how it works. And although my dad and my mom would talk about, healing by faith and being very religious and spiritual and advising people and engaging with people, my sister was never depicted as someone who needed to be healed or needed to be better by the grace of God, right? Like, prayers for my sister was always just like, don't get malaria, feel well. Like, it wasn't like we want her to not have autism and be verbal. And so I think I grew up in a world where I was just very curious. Like, why is it this individual seems so different from other people, but yet when she's with her group of people, she fits right in?
Right.
Or why is it that families in Ghana don't allow their kids who have developmental issues or consider special needs to just hang out with each other, right? What is this fear? I also noticed that whenever we would go to the hospital, my parents, I don't know if it was fear, but I did recognize as a kid that they would get apprehensive before we went to the hospital. And they would be like, well, which nurse is there? Which doctor is there? Who's going to be there? How many other people are going to be there? Who's going to be looking at her? And so I realized very early on that to be someone with a mental health disorder in Ghana, or maybe now that I know anywhere, is that you are othered. You are an other person, and other things need to be done to support you. And everybody sees you as an other. So then I got fascinated by that. I'm like, what is this othering thing? Like, who gets to decide who's an other, who is part of the group, who's out of the group? And then lo and behold, I land in America and there's so much othering. Like, this person is another, that person is another. And then I was even more fascinated by it. And as I said, I was in the US from 92 to 96, so the O.J. Simpson case. And I remember 4th grade and us sitting in class in Kentucky in a classroom of the only, and this will be interesting, I've only had 2 Black women as teachers, Black American women as teachers. Yeah. One was in 4th grade and one was in 12th grade, and that is it. And I've been in school for like hundreds of years. And I've only had two. And we were in her class. Her name was Miss Goodlow. And I remember when they said the verdict, there was a clear difference, even in us kids, what we thought was right and what was wrong. And a lot of it was just based on ethnic alliance.
Yeah.
And I remember very quickly after there was like an intercom and they were like, Joyce Fokuo, your parents are here to pick you up. And my mom did not let us leave the house until until she thought it was safe and riots were over, right? Because for her, this was also brand new. Like only time she had been through riots in Ghana was when there was a coup. People didn't just riot, right? Like we're not very...
No. Right.
But yeah, like back in the day, people weren't just, rioting wasn't something, or protesting wasn't something that happened very frequently. And so for her, it was like scary as opposed to like an exercise of civil rights. And so the long story short is I was brought up in an environment where I had direct observation with someone who was quote unquote different. I was fascinated by the mind because I was always trying to get my parents, as I got older, I was like, I want to see her brain versus my brain. Like, is there a structural difference? So things like that. I just got very fascinated with it, and then just kind of started reading and getting more interested and thinking about interventions. And I will say, because my father is a minister, one of the first interventions I was trying to get done in Ghana was through churches. And what I found out was that when you have someone with a mental health disorder, especially the ones that we consider to be more severe, so things like disorders that have an add-on, right? So like depression has a takeaway. So if you're depressed, you become quiet and you want to be by yourself. Exactly. But when you have something like schizophrenia or any kind of psychosis, there's an add-on, right? Yes, there are some negative symptoms, but there's definitely some positive symptoms.
Right.
And when people have those positive symptoms in Ghana, what they'll do, they'll take you to the hospital. They'll get you some meds. Once you're stabilized, a lot of families will take you out of the hospital, the psychiatric hospital, and then they'll put you in a prayer camp. And they'll keep you in the prayer camp for like a week. And then once the pastor says that they've done their prayers and, you're doing, mind you, this person is still on meds, then they take you from the prayer camp and you just tell everybody you were at a prayer camp, as opposed to saying that you were at a psychiatric hospital.
Because of the stigma.
Because of the stigma and the prayer camps, right? Because this is all cultural. If you told an American that I have schizophrenia and I went to the hospital and then I went to a prayer camp and now I feel better, they'd be like, go back to the hospital, do what you need to do. But Ghanaians find it far more tolerable and they believe it more, right? So someone who doesn't even have the disorder believes that if you went to a prayer camp, you are more healed than if you just went to the hospital. And so I have a great interest in that, and I've been able to sit on some in the background of some studies and watch how that has happened. Now in Ghana, the DSM-5 has been translated to Chi-Nga. That's all psychologists in Ghana doing that. There are 2 prayer camps that are working with across psychiatric to help people transition from the psychiatric institute to the prayer camp and then home for reintegration. And it just works better. There's, and now there's more work with Malams as well in the northern region so that they can do something similar. Is that, if someone is ill, let's not tie them down and wait for prayer. Let's get some meds on board, get them stabilized. And then we pray as we're doing that. But in terms of reintegration, it's much easier if you go to a prayer camp or you traveled to Kwai and then you came back, as opposed to saying, no, I was unwell. And so I went to the psychiatric institute.
Right. You've touched on something I find really interesting in just how culture really shapes practice. So in America, we have such this firm notion, and there are reasons behind it, of course, about separation of church and state, right? Freedom of religion. So you really don't, it's just not the culture to integrate faith or really talk about Christianity in the context of academia. And I was a psych major in college, and I can't remember faith ever coming up in any of my psych courses as an alternative. And so I'm curious, is it sort of like a frustrating thing for you as a practitioner that you have to sort of maybe adopt or change different ways of going about things in America versus Ghana? And I'm curious, since I believe you did all of your undergrad and your graduate school here in the US, did you ever even get sort of like a tutorial of how to integrate faith practices in psychology, or was that something you had to kind of learn independent of your schooling here in America?
Good question. So it's interesting, right? The first part of what you said is that America tries to separate state, and we know that is the goal, but that is not what happens, right? We have policies, we have laws that are very, very religion based, as opposed to just like, state based. When I was a kid in Kentucky, we prayed in school.
Oh, okay.
And this is like early 90s, right? You would have the national anthem, you do the Pledge of Allegiance, and then there would be a quick prayer, and then you started your day. No, now we don't do that anymore. Kids don't do that anymore, unless they go to a private school where religion is a part of it. I was completely trained in the US, and so there were options for electives if you wanted to do something, spiritual or religious based, because American psychologists acknowledge that religion is a big part of how people live with themselves and how they live with other people. Mm-hmm. And even now at UIC, when we do intakes, there's a question that asks, like, do you have a source of spirituality or a source of religiosity? And so we know that it can provide solace, it can soothe people, it can provide just a routine, especially if you're someone who's religious. Which it can be great for people with depression. If you even go to like a prayer group, that counts as a pleasurable activity. But those are things that I've had to seek out, right? So my institution had electives. If I wanted, I could go to there are a few Jesuit academic institutions in Chicago, and if I wanted, I could take pastoral counseling at those institutions. I opted not to, mostly because I had a specialization, and so I didn't want to add more years. But also because I was like, I can learn this. I can figure out how to make this work for the people who want it to work. That being said, as you were posing the question, I was thinking about my clients that I've had along the way. And with the exception of older, so it's usually like older people, like 70s, 80s. And then sometimes with addiction work, some like 40s, 50-year-old ethnic minorities, typically Black American. Those are the only times where people have outright said, I want my therapy to include something about my spirituality. Right. I've had a few younger people who are like the children of missionaries, just because you're not going to find that many people who have kind of my background and as it relates to like being a missionary and being in two cultures. And so I tend to get a lot of those students as well. But very rarely do I get a patient who wants to incorporate religion or spirituality into their therapeutic work, because I think, as you said, most people in the US have been taught to separate those things. And if someone just wants therapeutic work that has a pastoral lens, then we actually refer them out so that they work with a pastoral counselor.
I see.
Right? So if like someone came to me and they're like, I'm having a crisis of faith, I am not well educated. I'm not an expert. I'm not an expert in that. But if someone is like, I'm really dealing with my depression, and I realize that being at church and being with church and praying and looking at my Bible and things like that alleviate my symptoms, then for sure we are going to incorporate some behavioral experiments and some activation with church. If you want it, if you're someone who's very interested in that and you don't want to get an MA in pastoral counseling, but you want to stay in the traditional clinical psych world, there are ways to get that training. And there are courses now that you can take even online. But most institutions will not have it on as an elective.
Right.
So if it's something you care about, you can add it on, but it's not something that most institutions have, unless you go to, again, an institution that has a religious like backing. So like, I would imagine the Davidsons of the world probably have religious courses, or faith-based therapy, or even like Loyola's of the world would probably have some religion and part of the curriculum.
Well, this is actually the first time I've really heard pastoral counseling broken down. So thank you for sharing that. Actually,
you're welcome.
Look into more.
Yeah, there's like a master's. You can get a master's in pastoral counseling, and then some seminaries you can have it as a certificate. So like my dad, for example, he did not do the certificate, but he has a friend, and this is like early 2000s, even like 2010-ish, he had a friend who worked at, now granted, he has a different background, right? Because he has a daughter with mental health issues, with intellectual disabilities. So he has an in at the hospital, right? So if you came to him and you were describing things, especially things around addiction or things around I think his lights go on when he's like, is that mania? Then he's like, call this person. We'll pray, but call this person so that they can have someone who is trained in that to take care of them.
I see. Okay, that's great. That's really interesting. And hearing sort of about your dad, and I can already see how much of an influence he was in your life and kind of shaping your ideas. I'm curious to go back again to schooling. When you think back to all the training you received, I know it's a lot, but when you think back to the PhD at the Illinois Institute of Technology or internship at UC San Francisco, can you talk about a particular mentor or mentors that really shaped the clinician you are today?
That is a good question. Yes, I've had some really good mentors. I've been very fortunate. My mentor at Illinois Tech, so his name is Patrick Horgan. He is very well known for stigma work. He does a lot of stigma work. The mechanism he uses for a lot of his stigma work when I was there was contact-based interventions. And that was something that I was very passionate about. So after undergrad, I worked for, which I suggest to everyone, work as an RA. If you want to go into academia or you want to be a psychologist, work as an RA, because it gives you, especially with grant work, it gives you an opportunity to see all the pieces that go along with getting a grant and managing a grant. So I worked for 2 years at Northwestern as an RA in David Moore's lab. And that was the first time, and I was just doing calls, right? Just doing assessments over the phone. It was the first time, I think I'm aging myself here, but it was like 2008 and it was this big study and we were doing telehealth, right? It was the first time we were doing CBT telehealth. And I remember a lot of especially the women, they would say, I'm so glad that my therapist is over the phone so that I don't have to go to the hospital and tell anyone what's going on with me. I don't want people to know. I don't want people to think I'm weak, so on and so forth. And I remember that was the first time I was like, what is this stigma thing? Like, is that what I'm getting a whiff of? And Patrick Horgan he's in Chicago. So I sent him a cold email and I was like, can I just talk to you about this? And then we talked and he was like, you should apply here, right? Like if you're interested, because I was going to apply to a lot of social psych places or because I thought I just was interested in like discrimination and bias from the mind standpoint. And he was like, there are things you can do to like not have people be biased, right? So, go a little bit beyond the undergrad thought of like, what is the problem, but also how to solve it. So I think Patrick Horgan was a really good mentor. He had a clear idea of how these interventions would work. He had a lot of extensive research work and getting grants from NIH. And he taught me the machine. Now, granted, as a grad student, I thought the machine would eat me up. Like it was just too much. Like this man would have a 5-year grant and then year 2, he's writing the next grant and he's writing the next grant. I was just like, this is not, I don't know if this is the life I can lead. But I also knew that I wasn't going to be 100% a clinician. So I figured I had to kind of figure out other ways of doing that. When I went to UCSF, I worked with 3 actually mentors there that I thought were really fundamental for my development. Clinically, I met and worked with a woman named Valerie Gruber. And Dr. Gruber is like she's just like any and every single clinical intervention you've ever heard of. She's either done research in it, helped someone with it, helped write it. So she just knows, right? So like you're talking to her about a client and you're like, this client's having a really hard time understanding their thoughts and feelings. And she's just like, is your trauma dialectical? Just move to dialectical. They need to feel safe. All this thinking stuff is not going to help. Let them feel safe. Or, I'm dealing with because I worked at a methadone clinic. Dr. Gruber works out of a methadone clinic. And I would be like, I don't understand what's going on. Like, why would someone want to get less of their methadone just so that they can use on top of it? And she was just like, well, that's your bias. They get to define recovery how they want. And I was like, oh, snap, you're right. I do have a bias. Yeah. I'm thinking like everyone should just want to never use heroin again, right? Or opioids again. So she was really good at helping people, and not just me. She's won career awards, and she was really, really good at helping people not only be aware of their own biases and how that impacts clinical work, but also she was really good at meeting the client where they were, right? So if I had a client and I'm like, this client will only talk to me if we go to McDonald's. She's like, well, what are you doing? Go to McDonald's. Like, why are you trying to get them in the clinic? If they'll talk at McDonald's, just go to McDonald's, chit chat with them, walk around with them. Of course, maintain confidentiality as best as you can. But if the person won't come in, go to where they are. And so that really opened up my mind in terms of not just clinical work, but also research and academic work. So she's the first one. And then I met another person. His name is James Sorensen. He has since passed away, but he was also someone who worked in the machine and had all these grants all the time. But the way he managed the machine, now granted, I was also older, right? So I'm like, this is postdoc. The way he managed his machine just seemed a lot more pleasant. So you could tell he was stressed, but like, he was still like cracking jokes. He would come in with a riddle every day. He would make sure like during our supervisions, and if they were early, he would offer to make me oatmeal. Like, he was just very, I don't want to say he was go with the flow, because he was very type A. He got things done, but he was just very, you could tell that although it was stressful for him, he would do everything he could to make sure that this thing that he enjoys does not feel like work. So even if that means he's going to sit there with his intern and you're just going to write research ideas. Like, you don't have to write a grant, just write the research idea. What would be the question? How many people would you want? We would do this exercise where he's like, what's your wish list for a grant? Like, how much money do you want to get? Like, things like that, where it makes you excited. You're like, oh yeah, I'm writing a budget.
Right.
Right? Especially when like I was only getting grants for like, I don't know, 10,000, 5,000. They weren't huge grants.
Right.
But I think his philosophy was like, if you can enjoy it with 10,000, you can enjoy it with 4 million. You can enjoy it with 6 million. Because if you can make it work with this small amount and you're still excited, you can manage it if it's a bigger amount.
Right.
So I got that from.
You found that true? Now that you're more, you find that really true?
I do, because I feel like the things I was stressed about when I had very little research money are still kind of the things I stress about now, but now I understand that some of the stress is just in my head, right, and that some of these issues can be resolved if you talk to the right people. Like this machine, like the gears of this machine are people. So you can talk to people, these gears can work in your favor. Right. It's not going to eat you unless you let it. So I think one of the things that I had a hard time recognizing in grad school, because I'm also, like when you're in grad school, you're doing graduate work and you're also trying to do your research and you're also learning clinical stuff. So having all that while also like watching this mastermind write all these grants, I was just like, there's no way. There's no way. But with Sorensen, I was like, oh no, there's a way. You build a team, you build faculty around you, you get a staff around you. You know the people who can help you, you know the people who can support you. And I think with Sorensen, we very much connected on that idea of like, if there's a will, there is a way. Like there is a way you can get this done. You just need to kind of figure out ways to think outside of the box.
Right.
Yeah.
I love that.
So he's right. He was right. He knew it. He knew that. And then my third mentor was Dr. Carmen Masson. And Dr. Masson did a really good job of teaching me that the grant you have, you may not love, but it is a stepping stone. And I remember she was like, I know you want to do stigma work. I know you want to do training, but there's a great implementation grant right now. And I think you would be good for it. And I was just like, implementation? That doesn't sound fun. That sounds like an evaluation. Which is funny because in grad school, I was like, I'm going to do program evaluation. And so she was like, yeah, just learn it. I think you'd be really good at it. You're good with people. You're good with social, with community engaged projects. Try it, right? Like if you get this grant, you work on this grant, it might not be the most exciting thing for you, but you're going to learn a lot. And it's going to be a skill that you can use for your next grant.
Right.
And she was right. Because now I'm on a multi-site grant and I am doing all the implementation work. And I wouldn't have gotten this opportunity if I didn't have those skills. And so I think she makes, and she, I still talk to her now. She still mentors me. And sometimes I'll say like, I don't want to go for that grant. And she's like, Konadu, look at your schedule. Is this something you care about? Is this something that you can learn something new from? And if it is, use it as a stepping stone. So I think those three have been very helpful for me in terms of like shaping the way that I think and how I interact with not just participants, but also with patients.
Right. And it's funny, my next question my follow-up was going to be, what's the best piece of advice you've gotten? And you've already dropped so many gems. I can tell these mentors really kind of shaped you to now be a dispenser of this wisdom. And I love that. I love hearing about
that. Yeah, it is. This is something that I think I learned a little late in life or late in my career. So take this wisdom, those who are watching and listening. There are opportunities through NIH that are specific for minorities. Now, be that as a woman or be that as an ethnic minority or even a sexual minority. Take them. Don't think that they are some perverse exercise in affirmative action. Don't think that this is just them trying to, make you a workhorse or da-da-da-da-da. Because, and you know what? Let me not say that. There might be some truth in that. I don't know what percentage is that, but there might be some truth. So let me not dismiss people's feelings. Right. However, in those programs, there is excellent mentoring because people recognize, right? So I named 4 people. I named Patrick Horgan, Valerie Gruber, James Sorensen, Carmen Masson. Carmen Masson and Dr. Gruber are women. Dr. Masson is a ethnic minority. She's Latina. These other 3 people have committed their careers to mentoring because they recognize that ethnic minorities have difficulty in getting grants because they do not get proper mentoring. And then the other thing we realize in grant work is that it really does matter who's on your grant. And if you are applying, so for example, let's say you're applying to the National Institute of Mental Health or Minority Health, that institute doesn't get a lot of money. So if you have a great idea, but you don't have some big names on it, it's never seen or it's never discussed at the level that it could be discussed. And you don't learn that unless you have a mentor who knows that. Right. So if they're like, no, don't use this new person, use this person who has a little bit more experience because their name means that this is something that's going to get done. You're like, oh, I would have never thought of that. Right. And so some of these programs really give you excellent mentoring in a way that you're not getting that kind of mentoring in grad school because you just don't have time for it.
Don't have time, yeah.
You just don't have time. But like internship, postdoc, do those things, get those opportunities, do a diversity supplement, do everything to get your name known at NIH so that you have other opportunities available to you. And then you can also pull people up along the way.
Definitely. Yeah. I was blessed to receive a Fokuo diversity supplement, so I know exactly what you're talking about. And I had the same initial little bit of apprehension of what is the agenda behind this, but I also kind of followed my gut and said, you know what, I'm going to get great mentorship and have a great opportunity. I'm so glad I went for it and I received it because it opened so many doors for me.
So many doors, right? Because now people know your name.
Yeah. Yes, for sure.
Yeah, and I love that. I love when people are like, I love when a non-Ghanaian says my name properly. I'm like, oh.
There you go. That is a plus. Yeah. Not Nene, Nana.
Yeah, right? When someone knows, it's like, they're like, no, that I love it when they're like, oh, it's not Konadu, it's Konadu. I'm like, you're right, it is Konadu.
Right.
So yeah, if you have those opportunities, take them. Because the worst thing that can happen is that you don't get in. You just apply again.
Yep. Definitely.
Give it to someone else to look at, fix whatever needs to be fixed, put it back in. You have a greater chance the next time.
Definitely. Now let's talk a little bit more about grants and awards, shall we? So one thing that I had to shout out, and I think you're too humble to have brought it up, but in your short career, you were able to receive the Judy E. Hall Early Career Psychologist Award from the National Register of Health Service Psychologists. And that granted you a stipend of, I think, what was it, $10K or so?
I think it was $10K,
to have a project of your choice. So first of all, that's amazing. Congrats. I know these things are so competitive and hard to get. And, it just speaks to your abilities that you were able to accomplish this. And I'm curious, what did you use that award stipend for? Can you tell me a little bit more about this project that you invested in?
Yes. So what I was interested in for this particular project, as I said, I'm interested in stigma and reducing stigma, especially with healthcare providers. Because the thing is that we forget that our providers are people, right? Like you go to see your doctor, your primary care doctor, or your primary care doctor usually, and you are going in with all the experiences you've had that day. You got on the bus, you drove, you had to deal with your family, so on and so forth. So is that provider. Yeah. Plus a lot of other things that are happening in their world. We know that providers are usually, especially when it comes to things like substance use, we know that providers have, and this is changing, but tend to have a little bit more of a hesitation with taking on patients with substance use disorders, with managing patients with substance use disorders. And a lot of it is just burnout, right? Because you have, when someone has a chronic disorder and you're just watching them deal with that disorder, it can make you feel as though you are not very important, you're not very helpful. And most people who go into medicine are people who want to help, right? So you're basically telling this individual who's motivated to go through this grind of med school and then grind of residency and then the grind of fellowship and all the things most of the things that's motivating them. Sometimes it's their parents, sometimes it's kind of what kind of power and prestige they get from it. Money. But if you want money, don't go into science. Like, don't go into medicine. Go into go into something that gets you money fast.
Yeah, that's right.
But yeah, money, prestige. But for the individual, a lot of individuals are motivated to help, right? Like, I'm helping, right? So if you spend a very long day in the wards, you're like, it's okay, I helped this person and that person and this person. Mm-hmm. But when you're working with people with chronic disorders, it doesn't feel like you're helping. Mm-hmm. It doesn't really feel like you're doing much because you keep seeing this person and they keep having the same issue. And so a lot of my research, or what I use that research to do, the first part of it, because this is another great tool for those of you who want to go into research, there's a fallacy that you need a large amount of money to do a big project. That is not true. I mean, okay, let me take that back. It's true.
Right.
However, you can break up a research study so that you can use smaller pots of money to get outcomes towards whatever the big question is, right? So what I did with that 10K was I started the process of trying to figure out what is the lived experience of these providers, mm-hmm. right? So if you're a provider and you're providing, let's say you're providing medications for opioid use disorder, and you're watching people, and now especially in Chicago and other parts of the US, we have so much overdose, right? And then COVID happened, and then the overdoses got worse. And I wanted to know what narratives these providers have about themselves and about the people that they're helping. Mm-hmm. Now, see, when I wrote this grant, I wanted to know what providers knew. I wanted to know what patients knew. I wanted to know what the staff knew. And you can't do that with $10,000, right? So I was like, okay, I'm going to start with the providers. I'm going to start getting their narratives and figure out how it is that they are dealing with this. And what I got in some of my interviews was it's a ton of trauma. Like, these providers are just having to absorb a lot of trauma. And we don't really teach providers what to do with that trauma, right? So
trauma, if you think they've observed during their practice, okay.
Yeah, traumas that they've observed, right? So they've observed these traumas from their patients, but also the interaction. You can feel like vicarious trauma because you're listening to someone talk about these things, and then you're watching this individual struggle to maintain things that you, as a provider, is just like, why can't you? Mm-hmm. Like, you could get housing, you could get food, like, what is happening? Why, you could get your kids back. Like, why are we struggling with the same thing over and over and over, even when we have medications to help you? Right. And so I think what I was actually surprised by was, again, the amount of trauma. I thought a lot of providers would just talk about the system that they're in, right? They're in the thing about stigma and discrimination is that we all assume that we are enacting it. Like, I did something discriminatory. I did something, I have this bias, da-da-da-da.
Right.
Sure, that is happening. But we are in a system that is constantly biased. Mm-hmm. Right? So even if you want to or not, you are engaging in a biased system. Yeah. Right? So UIC is the only institution in Chicago that takes all forms of insurance. So if you're working at a different institution, there is a bias towards people who have a certain type of health insurance. And that's just right off the bat. You're not doing it per se, you're not enacting it yourself, but you are part of a system that does enact it. And so I think that's what I thought I would hear a lot more. I would hear people be like, well, in the notes it says mean things, and this clinician and this nurse, but it wasn't that. It was just like, I have to watch people be sick all the time, and it's hard to do that.
Powerless to stop it sometimes.
And it's so, oh my goodness, that sensation of powerlessness, which is for a lot of people, they went into medicine so that they would have some power. They could help people. And yet, and now you're in an institution or you're helping people who are just like not getting better as quickly as you would think. And for specialties such as like oncology or even pediatrics, there's a lot more work done on resilience and how to deal with these negative feelings. But if you're, if you're someone who was like a general practitioner, you're not getting a lot of this unless you, again, just like I did, you would have to go out of your way and find electives that will teach you this, right? Or you're lucky and you find an attending who does a really good job of this. But the number of times I've heard medical students say, I was working in the ED and someone died. And then the attending was like, all right, on to the next.
Yeah.
I'm just like, oh, that's hard. That's very difficult, right? And for a lot of people, that's why they don't want to work in the ED or in the ICU. They're just like, I don't know how I would deal, right, with this kind of, honestly, it's just compassion fatigue. Like you just get very tired of feeling like you want to help, but you cannot help.
Yeah.
So that's what I use the money for, and that's the research that I found. And then because of that, I was able to use the preliminary results. And I am now on a different study through Illinois. So Illinois, I'm sure you guys know this. This is another good tip. Almost every city and state have money towards public health. And because of substance use and overdosing, there's always like a little bit of money from the federal government that goes to the state and to the city to help with that. That's a really good place to look for funding and to do it with someone else, do it with a bigger institution. So I'm doing it with Rush University. And what we're looking at is that we are using NET is like a narrative-based exposure therapy. So we're going to use NET to now talk to these providers and see how we can help them resolve some of their trauma. And now that we have more money, we can also talk to the patients and talk about their trauma. Because a lot of patients in research, you'll find articles about how patients don't go to the hospital because they just don't want to be treated poorly, right? Or a patient will talk, I've heard stories myself. And, I had a client come in San Francisco, and the minute she came into my office, I was like, I smell rotting skin. Like I immediately was like, this has never happened with her before. What is going on? And she was like, oh, I have an abscess. And I was like, well, how long have you had this abscess? And it was huge. It was like all through her neck and down her shoulder. And I was like, why don't we go to the hospital for this? And she was like, oh, well, I'm waiting for the physician here at the clinic to look at me because I don't want to go to the main hospital because they'll talk about me. They'll say, because it looked like it was a puncture injury. Mm-hmm. Her trying to get her drug. And so she was like, I don't want to go. Like, they're going to be mean to me. And so she was just letting this infection fester. And I was like, well, let's just go together. And she was like, oh, well, maybe if I go with you, they'll be nicer to me. And of course we went and everything was fine, but she's right. I was there, right? So she was like, oh, they're nice because you're there. They're nice because, and she was, everyone did seem quite happy to see her. We went to wound clinic and everyone was nice about it. They gave her extra supplies. And then after we left, she was like, that was only because you were there. They wouldn't be that nice to me if I went alone. I don't know, but I do know that she was scared to go. And then when she went with someone who worked at the hospital, she was less scared. And so that's scary, right? And if she goes home and she has a friend, and she was actually living in an encampment, if she has a friend who also has an abscess, she's not going to say just go to the hospital. She's going to say, well, go to the clinic, find a staff member, and then go to the hospital. Right. Because that has been the experience that for her has not been stigmatizing, has not been traumatizing. Right. And I also think in this work, what I found is that when I do presentations, I ask everyone, I do like a word cloud, and I say, tell me the stereotypes you know about people with substance use disorders who are dealing with addiction. And it's usually very negative stereotypes, right? Thieves, dirty, da-da-da-da. And then I talk about like, oh, they're positive stereotypes. How come you didn't think about any of those? But then once I did this presentation and I saw industrious, and I hadn't seen someone give like a positive stereotype before. And so I said, who said this? And this guy was like, oh, in my neighborhood, there's a person there with a stimulant use disorder, and he just fixes cars. Like if you need your car fixed, he will fix your car, and you don't have to pay him a lot of money for it, and he will do it, and da 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 da. And so in his mind, people with stimulant use disorders can be very industrious because they get a lot of things done. But I think as clinicians, and the patients do the same thing. We forget that we're dealing with other people, right? So clinicians forget that you're dealing with someone, especially if the person has a substance use disorder, someone has been homeless. You're dealing with someone who has a very acute ability to recognize people who are genuine and people who are disingenuous.
Yeah.
If at any point they notice that you are being disingenuous, they will discontinue care. Because what's the point? In the same way, patients come in and they just assume that this provider has it all together.
Yeah.
They have a job, they have a title, they probably have a car, da 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 da. And they have no idea what's going on in that provider's life, right?
Yeah.
And so I think a lot of the time our interactions feel and are sometimes very unpleasant or extreme. The extreme cases that they are not trauma-based care. And in the process of that, we lose opportunities. We lose opportunities to get patients engaged. We lose opportunities to get providers engaged because they're either burnt out or because they've had a negative experience. Yeah. And so the short answer is that I used it to figure out why providers were so sad. And then I was able to use that information to get a bigger grant to figure out how to make them not so sad.
Right. Yeah, you took a little baby steps and it really escalated to something that you're now doing, really able to dedicate more energy to, which I love. I really love that. And just from a very personal note, I have, and I'm actually glad to hear that's what you used the stipend for, because I have so many doctors and residents and med school students in my family right now. And, not that I'm a qualitative researcher, but just hearing their stories, I really see the need for what you're doing, because you're right, that often doesn't get addressed. It's just, especially in a lot of, not just in med school, but in grad school, there's this like culture of, thick skin. You have to get through it. You have to spend 24-hour shifts in the year. It's part of, it's part of this experience, which it is. But I'm so glad to hear that you dedicated resources to really understanding these stories and really addressing those needs. And I know just for my own just personal interaction, there are so many people who hopefully will be listening to this who would love to engage with you in those kind of resources and kind of hear your sort of insights into how to take care of themselves mentally when they're working those long shifts or in med school and it just seems so draining. So thank you for the work you're doing. I really appreciate that.
Oh, thank you. Yes, I like it. I like it. It's interesting to me. It activates my intellectual curiosity. And yeah, I think it's just needed.
Yeah, definitely.
Yeah. I mean, I think they've tried before, but again, research is all just like where the federal money goes. And I think right now, also because of COVID, federal money is kind of like our poor doctors, because doctors and nurses during COVID just witnessed so much death, far more than they typically do. And then some providers didn't even get to work, right? Like I, as a psychologist, I could do telehealth and talk to people that way. But like, what was radiology doing that first couple of months where we didn't know what to do because they couldn't be on campus? And so I think it was a hard time. I think it was a hard time. And I think that our federal money and federal spending is recognizing that we need to do something for our doctors more than just stand outside and clap when their shifts are over.
Right, definitely.
Which was nice. It was nice, but
yeah, definitely.
Let's do a little more.
I love that. Now, can we shift to a whole different population that I know you work with?
Yeah.
So I was informed that you are quite into basketball, and I'm wondering if that kind of shaped your interest in working in sports psychology. And I did want to share that because you mentioned RA. So one of my first jobs after college was an RA for a concussion-based research group. And as you can imagine, our bread and butter, so to speak, was athletes. And I actually continued a lot of that concussion work and specifically focusing on psychological distress and cognitive difficulties in athletes after a concussion. And I did that for many years. And so I'm kind of interested in seeing if you kind of have this perspective too. One unique aspect of working with athletes, I found just in my capacity as working in research under neuropsychologists, is athletes seem to have this very almost inherent type A personality and almost, I would say, very competitive. I can remember when I was doing a lot of post-injury neuropsych assessments and balance tests with athletes. And so I recruit an athlete and a control and then, do the whole baseline assessment. Then if they get an injury, I follow that athlete post-injury time points and also have control. And just the way I would be doing a test with an athlete, and it'd be like, oh, somehow they found out who their control was, even though we're supposed to keep that blinded. They'd be like, oh, how did John do? Did I do better than him in the memory test? Like, hey, you're injured. This isn't a competition. You're recovering from a concussion. You're not going to do as well. And it's like, no, but I think I did better than him. And then I even hear them in the locker room saying, oh, I got a blah, blah, blah. And honestly, I got a blah, blah on the balance test. What did you get? Like,
it's like our former president, man, camera.
Right. Right. This is about post-injury evaluation here. We're not trying to make it into a little side, a little competition, but athletes just seem to have this competitive nature about them. That's one thing I kind of notice is very particular about that population. I'm kind of curious, in your work in sports psychology, is there any kind of unique aspect of working with that population that you find interesting?
Our athletes, I absolutely agree with what you said. Our athletes, the culture in which we, especially our young athletes, we put them through, our youth athletes and then become professional, they are taught to just tolerate things at a very high level.
Yeah.
Right. So you'll meet an athlete with something that hurts and they're like, no, I could just work through it. I just do it harder, do it better, do it harder, do it better. And so we put them, and some of this might just be, right, nature versus nurture. You might just meet someone who is just naturally very competitive and can tolerate a lot of distress and unpleasant things in order to get whatever they think the outcome is, right? And then we pour into that. We just pour into that and we give them more cognitive rules to cement that and so on and so forth. But then what happens, like just like you described, is that someone gets hurt. And we know not all our undergrad athletes become professional athletes, right? The number of basketball players who play during March Madness is going to be significantly small when it comes to draft day. They're not all going to be, they're not all, I mean, I was going to say LeBron, but LeBron didn't go to grad school, didn't go to undergrad. They're not all going to be,
Caitlin Clark, though.
Yeah. Exactly. Right. Yeah. Exactly. They're not all going to be in the WNBA. They're not all going to be in the NBA. Right. And then what do you do? What does that person do? Yeah. Now they either have to find something else they're very competitive in, right? Because you have to deal with that sensation somehow, or they need to find something that they can just tolerate. Right. And it's hard and it's a challenge and it's unpleasant, but they can just tolerate it because that is all they know.
Right.
So I think that I definitely agree that it does. Not all of them, not every athlete seems very type A, but they all become very regimented. Even working with performers, right? So right now I work with a lot of dancers, a lot of elite dancers, and I worked with opera singers and gymnasts, and it's the same thing, right? It's this desire. Well, okay, so we're doing CBT, but like, are my reframes the best, or could they be better?
Yeah.
It's like, your reframe is just yours. Your challenge is just yours. No one is evaluating this, right? Or even as you were describing, you have family members who are in medicine. That's all performance, constant evaluation. And so you become this person who doesn't feel whole unless you're doing something that's really hard or very unpleasant. Yeah. And you have to do it at not the average level, but above average level. Right? If everyone's getting an A, you as an athlete, you're shooting for an A++, because that's the only way you're going to be noticed.
Right.
So I do think a lot of it is the culture that we have around it. And as you know, the culture around it is money. And fame. And so it makes it very difficult to convince someone when they're in it that this might not be the healthiest thing for you. It might be a little maladaptive. And if you talk to retired professional athletes, some of them will say that, like, I was maybe going a little too hard. Or like, so, and now because of the work I do with athletes, I do a lot of work with eating disorders. And I just didn't realize how maladaptive eating is involved in some sports, right? Boxing, wrestling, you have to make weight. You want to make weight in a way where you're the heaviest person in that weight class. So you are gaining weight to then lose weight just so that you can have this one event. And then what do you do afterwards? Like, how do you go back to eating regularly afterwards? And so I think our athletes are, if we, they're gladiators, but how well functioning were gladiators from back in the day, right? How many of them were holistic in their approach? So it's, and we as cultures globally are not very kind to our entertainers because there's fame and money involved. But that is one of the things that I would really like to delve in a little bit more, is how to create a little bit more of a supportive environment for our athletes, because they bring colleges and universities and and these I'm thinking of the Bulls, like they bring so much money to communities and so much joy to families and friends and so on and so forth. But then we forget, like, oh, this is a person.
Definitely.
This is a person.
Yeah.
We need to take care of all of them and make sure that they're all, all of them are doing well. And I do think nowadays we have a good examples of that, right? As much as we say negative things about social media, we are recognizing that more and more of our athletes are just humans. And because they show us they're humans, right? They show us that they're pregnant. They show us that they're going through a divorce. They show us that, just like very human things. And so they show us that they don't always say the best things. And so I think because of social media, I think we're getting a little bit more of a glimpse into like, oh, this is a person. And we need to recognize them as a person and not say hateful things to them because they missed one basket at the end of a quarter that you thought they should have.
Right. Yep, definitely. Yeah. This is very timely for me because in my undergrad institution, there's actually a big headline now that the men's basketball team has voted to unionize. And that's opened up a whole new can of worms about what does that mean? Should we pay student athletes for their time? Is there labor that brings in money, worth, compensating? So I'm glad you brought it as a whole because it's a very national headline right now. So
that's exciting. I'm like, which institution is it? But we can add that offline. But also now you can pay undergrad athletes for their image, and that was something that wasn't happening, right? So you have these kids whose faces are in video games and their names are on jerseys, and they get commercials. Yeah. And they're just, because they're kids, they're happy to be at the commercial. I'm like, your institution is making money off of you for this, right? Like not just like we're making money because people are buying your jerseys, but we're making money because people are watching you. We have TV broadcasts that we're making money from, and so I think it's a great time to have this conversation. I'm glad the NCAA is thinking about doing this and getting involved. And I mean, the state of California has done some great stuff. But yeah, I think it's timely. I mean, I think our athletes are starting to recognize that the approach that they created collegiate athletes with is maybe not the best. And there's some ways that there's some ways they can fix it. Some very small things they could do to fix it and some big things they could do to fix it.
Yeah, definitely. Now, I want to talk a little bit more about my experience with athletes because it kind of dovetails into something that I really have appreciated about hearing your journey, which is when I worked with a lot of the athletes in the concussion studies, part of the study was doing exit interviews for people who were finishing their career. And a lot of times finishing career didn't just mean graduating. It meant, ending your career because of a career-ending injury. So I would see a lot of athletes come in for their exit interviews, which is all part of this biomarker study that I was a part of. And they were coming in to see me because they were leaving football because they had suffered a major career injury or just they had one too many concussions and they were done. And they would come in with so much sadness, and I could tell like this was like devastating for them. Their whole career, what they thought they'd be doing maybe in the NFL was over. But as a researcher, because I worked in a research capacity, I was kind of trained to be very sort of stone-faced and neutral, right? How is your, administering the PHQ-9, being very stoic about it and not offering any kind of counseling or any kind of empathy. I had to be very restricted, and that's how I was trained. So it was very hard for me because I consider myself a very empathetic person. But when I'm hearing someone talk about the thing, and I just have to be very stone-faced, and I can tell even answer some of these questions is causing them a lot of distress. But still trying to kind of maintain that neutrality of a researcher, so it's not influence their answers or anything. That was very hard for me. And one thing I remember kind of taking away from that is like I like research, but gosh, it's hard to like kind of just be limited in that capacity. And I wish I could have helped a little bit more in like a more clinical capacity. And I see that you've been able to kind of have the best of both worlds, where you've done some institutional work, but you also did some private practice work. And I know some people feel like they can only be in one box a lot of times after their training. And I'm kind of curious, how are you able to sort of have the best of both worlds? And do you think it's actually feasible to kind of work in your capacity of, doing institutional work, but also doing something more private practice or doing more research versus doing more clinical work? Is that something that you think is feasible to achieve in a career?
It is very feasible to achieve it, and you can achieve it in any way you want to do it. Like I said, when I was going to grad school, I thought about doing social psych, and I ended up not doing social psych because exactly what you described. I wanted the ability to do some clinical work. Right. And that's why I like to I describe my appetite for work to be like Thanksgiving dinner. I want a little bit of this. I want a little bit of that. I want a little bit of this. And then if I don't like this, I'll take it off. I'll get something else. Or sometimes and so that's one way of doing it, is that you think about your effort and how much effort you can give towards different things that you're interested in. Another way of doing it, again, Thanksgiving dinner, is like sometimes if I have a small plate, I might just like start with my veggies and then I'll go back and then get some protein and then I'll go back and get some carbs. And so you can also design your career to fit what phase of life you're in, right? Yeah. So if you're, one of the things I've always said I would do as I funnel out of my career is that I want to go back to Ghana and I want to establish learning banks for people, because I think about all the kids that I knew in middle school and high school who were struggling in school. And I think back and I'm like, I think that dude had a learning disorder. Like, I really think he had a learning disability, because how were we in high school and he's struggling to know the sounds of words? Right. And he's just getting yelled at. And the teacher's not recognizing he can't read because of you. You should have taught him how to read better. And so, and again, that's not on my plate right now. Right. That's something that I know I'm going to pick up later on. But right now.
Yeah.
So yeah, it's very feasible. It's just not doable in grad school or even postdoc. I mean, I think grad school and postdoc are an opportunity for you to just explore and find the things that you like and the things that you don't like. I got a specialization in rehabilitation psychology thinking that I would be doing, like cool work with, like, now that we can have AI and we can get, people to have dexterities on artificial limbs. And I'm not doing any work with artificial limbs or injury even. But I do still have that knowledge, so I can apply it in a different way. I can apply it to athletes who are, post-injury, or athletes who are retiring, because I have a sense of that, like what that feels like to work with someone who has lost a major function of their life or a major part of their life. And so, yes, you can do it. Just give yourself time so that you can get to a place where you can figure out what you want on that plate, or when you want it on your plate, and how much of it. That's the other thing. Don't overdo it, because if you have a lot of things on your plate, everyone's going to be expecting you to be able to give 100% on everything. And you may just not be able to give 100% on everything.
Right. I love that. And you already answered my question that I had next, was kind of like a final piece of advice, but you already have kind of talked so much about it, which I love. And so I think I want to end this on, you already talked about in the horizon, you see yourself going back to Ghana and helping sort of establish schools footing problems, which I think is great. Oftentimes, I just from the time I spent in Ghana, there's such a stigma about, being dumb, or that phrase. And it's just like such a culture kind of like really teasing sometimes, and just to, dismiss someone as like, dumb, when you really don't want to peel the issue. So I'm so glad to hear that you're thinking about that. And so I just want to sort of have this as the ending question, because of the group that we're in. Why do you feel like it's important to kind of give back to Africa? Why is it important for you to sort of go home and take what you've learned in the US and apply it to Ghana? Like, what does that mean for you?
Excellent question. I think it's important. I think that I've heard so much about the brain drain and so on and so forth. I don't think you have to move back to the continent. I don't think you have to. I think there are ways that you can engage in the continent in a way that is helpful. If you want to move back to the continent, you can. They'll take you. They'll love you. You're helping, and so you can. But I think one of the fallacies is that we assume we have to be all or nothing. I have to be here, or I have to be there, and you don't have to do it that way. You can do it the way you want. Yeah. The other reason why I think is important is that at the end of the day, you're from where you're from, and where you're from will only get better if you roll up your sleeves and you help. And I think it causes me a lot of cognitive dissonance. Even hearing people talk about how, if you think about the comment I made earlier about Ghanaian politics, people love to rip things apart. This is awful. That's awful. They should do better. Blah, 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 blah. And I'm just like, but what are you doing? How are you helping in this process? And if you don't have an answer to that, then you should think about it. Because if this is a problem, it's something that you can help, right? Yeah. You can help that. So if you're a clinical psychologist or you're a neuropsychologist and you're just like, man, I went home and I heard this story about someone being tied to a tree because they have a mental health disorder and their family doesn't know how to keep them home. So this is the only restraints they have. You should have said something like, hey, have you thought of taking that person to a hospital? Because there are ways to help above and beyond just restricting them. Yeah. We're educated for this, right? We've gone through the process of being educated for this. And there are some benefits to that. There's some great benefits to that. let one of the benefits be that you help people above and beyond what you do at your job. And I think it's important to help the continent as much as you can, however you can.
I love that. That's a great note to end on. And thank you so much for sharing everything. I feel like I've learned so much from you, and I've just gained so much of a perspective on how this journey between transcontinental odyssey and just trying to figure out what your passion in life is. So thank you so much. I really appreciate it.
You're very welcome. This was great. Thank you so much for organizing this and working on this. It's important, right? We're people of the diaspora in a very different way. And so our thoughts and our actions are a little bit different from other people in the diaspora, but nonetheless, we're in the diaspora. And so it's important for us to have community, and it's also important for us to be able to answer some of these questions for ourselves.
Well said. Thank you, Dr. Konadu. I really appreciate your time.
You're welcome. Thank you. You're a great interviewer.